I'm Dr. Emily DeSantis, and I'm going to be speaking today about inflammatory lesions and dermatopathology. This will just be kind of a broad overview of a few inflammatory conditions that we frequently see. It's not meant to be a comprehensive overview, but should certainly provide enough of an introduction that you get an idea of how we approach things under the microscope as dermatopathologists. The goals of this presentation are to present a systematic approach to evaluating biopsies of inflammatory lesions. It is important each time we look at a slide to look at it in the same systematic way to make sure we aren't missing anything and we're seeing all of the important components of the tissue. We're also going to provide an overview of inflammatory patterns and the differential diagnosis associated with them, and hopefully provide pathologists with tools to become effective diagnosticians and clinicians to become effective consumers of dermatopathology, and to just get a better sense of our approach to slides as we're looking under the microscope and how that relates to what you are seeing clinically when evaluating the patient. When looking at inflammatory lesions, communication is extremely important. Many of the essential components of providing an accurate diagnosis for patients occur before the actual microscopic examination. So these include the biopsy technique, whether it's a shape or a punch, the size of the biopsy, the depth, so the location in the skin of the lesion that you're trying to assess, and the site of the biopsy. Clinical history is extremely important. This includes the age of the patient, the duration and distribution of lesions, any prior treatment that the patient may have had, underlying illnesses, and medications, including recent medication changes or new medications. Clinical photographs are extremely helpful for your dermatopathologist. So if you have access and the ability to take clinical photos of inflammatory processes, that is always very welcome and can provide us with some really important information. And always provide a clinical differential diagnosis on the requisition. When performing a biopsy of an inflammatory process, a punch biopsy is always preferable. We do often receive shape biopsies for papulosquamous lesions, so things that may be spongiotic or psoriasiform. And in some cases, these are sufficient, but in many cases, they aren't. So a punch biopsy, always preferred. At least a 3 millimeter punch is ideal. In shape biopsies and smaller punches, we may miss the critical areas that we're trying to assess, even if we perform multiple tissue levels, and it just increases the chance of issues with processing or just not being able to provide the information that you're seeking. So performing a systematic approach to biopsies includes initially looking at the slide at low power. I always like to start out at low power and get a sense of the tissue as a whole. At low power, you can get a sense of where the activity is, whether it's an epidermal process or a dermal process. It just kind of gives you an overall view of the tissue. And from there, I approach biopsies from a top-down process. So starting with the stratum corneum and moving to the epidermis, basement membrane, underlying dermis. And if a subcutis is present, then we evaluate that as well. This is an example of a punch biopsy. So on the left, we see a nice, very deep punch biopsy. So at this power, we can see that there is probably something happening in the stratum corneum, and there does appear to be some epidermal change, perhaps some thickening of the epidermis. And the dermis is fairly unremarkable aside from something in the superficial dermis that we can then evaluate at higher power. Over on the right, in the top image, we get a better idea of this thickening in the stratum corneum with possibly some parakeratosis, again, some thickening of the epidermis, and this mild perivascular infiltrate. And then at higher power, we start to appreciate that there is in fact parakeratosis, and then in the epidermis, there is a bit of spongiosis, so a bit of increased space between the keratinocytes. So this process helps us to kind of narrow down what our differential diagnosis will be and to identify any diagnostic features that may be associated with particular lesions. So before we jump into the overall inflammatory patterns, let's discuss a few commonly used terms in inflammatory dermatoses. The first is acanthosis, which I mentioned in the previous slide. This refers to increased thickness of the epidermis, or can be also known as epidermal hyperplasia. Psoriasiform hyperplasia is regular acanthosis, so regular elongation of the reedy ridges, classically seen in psoriasis, but also seen in several other conditions. Orthokeratosis refers to thickening of the stratum corneum, and parakeratosis is retention of nuclei within the stratum corneum, as we also saw in the previous slide. Dyskeratosis, which can be used kind of interchangeably with apoptosis, is premature or abnormal keratinization of keratinocytes, which results in a condensed eosinophilic appearance of the cytoplasm with a darkened kind of hyperchromatic nucleus. Inflammatory dermatoses can be categorized into several broad categories. These include spongiotic, psoriasiform, interface, which can be subclassified as vacuolar or lichenoid, pustular dermatitis, vesicular-bullous dermatitis, and granulomatous dermatitis. And in this first talk, we will focus on spongiotic, psoriasiform, and interface. And then in subsequent discussions, I'll talk about pustular, vesicular-bullous, and granulomatous. And then at the end, we'll try to put all of those together in an unknown discussion that includes all of them. Spongiosis is the presence of intercellular edema in the epidermis. So it results in increased space between the keratinocytes that appears as kind of white spaces or cleared out spaces in the epidermis. This allows us to actually see the individual connections between the keratinocytes, which are the desmosomes, and can also result in spongiotic vesiculation, where you actually get little vesicles within the epidermis. And you can see a vesicle in this right-handed image. We also see the presence of some inflammatory cells here within the epidermis. These are lymphocytes, and this is exocytosis, which is very common in spongiosis. Exocytosis is lymphocytes within the epidermis in areas of spongiosis. Clinically, with spongiotic dermatitis, the most common clinical differential diagnosis we receive is eczema, eczematous dermatitis, dermatitis NOS, rash, kind of a variety of things. And eczematous dermatitis can include atopic dermatitis, nummular dermatitis, contact dermatitis, eczematous drug reactions. So it's a pretty broad category. And there are some histologic features that can help us to narrow the differential diagnosis and arrive at a more specific diagnosis. But in many cases, there is a lot of overlap, and the findings really are nonspecific, and the best that we can provide is a differential diagnosis that requires clinicopathologic correlation to arrive at a final diagnosis. So clinically, eczematous dermatitis can present in several different phases. There's acute, subacute, and chronic. The acute phase is typically consists of erythematous or edematous papules and plaques, possibly vesicles. Subacute lesions are a little bit older and they may have some scale and excoriation. And then chronic lesions are more hyperkeratotic and can appear lichenified. And in severe cases can actually form nodules, which is what we see in Prurigo nodularis. Chronic lesions also often demonstrate post-inflammatory pigment change. There are histopathologic features that correspond to all of these clinical phases and can help provide clues to the diagnosis. In acute spongiotic dermatitis, the hallmark is spongiotic microvesicles, and macrovesicles can also be seen in some types of acute spongiotic dermatitis. The stratum corneum, because this is an acute process, typically shows a normal basket weave pattern rather than parakeratosis or any other alteration. And there often is a superficial perivascular lymphocytic infiltrate that's kind of variable. It can be very mild or a little bit more intense, and scattered eosinophils can also be seen. The differential diagnosis of acute spongiotic dermatitis includes contact dermatitis, dermatophyte infection, dyshidrotic eczema, an id reaction, or possibly an arthropod bite reaction. And in this slide, this is actually a shave biopsy. And you can see in this shave biopsy, going around in circles, why a punch biopsy is preferable to a shave biopsy. In this case, while we do have the majority of the epidermis, in some cases, in some areas, the epidermis is actually transected at the base of the biopsy, and we don't see the full epidermis. We also do not see any dermis except for this very, very superficial papillary dermis. So it's difficult to get a sense of the inflammatory dermal infiltrate, if any, and what cells are included. What we can appreciate in this shave biopsy are these very large macrovesicles. And we also see this thickened stratum corneum with a stratum lucidum, so we know that we are dealing with an acral site. So while this is a thickened stratum corneum, it doesn't demonstrate any parakeratosis that would suggest a more chronic process. So this is acute spongiotic dermatitis. As we go to higher power, we see that the inflammatory cells, at least in what we can see at this epidermis, are predominantly lymphocytes. I don't appreciate a lot of eosinophils here. And together with the clinical impression for this patient and the fact that we had a negative PAS stain, this is a nice representation of a case of dyshidrotic dermatitis or dyshidrotic eczema. Our next case is also a biopsy from the acral surface, as you can see from this stratum corneum. And again, we have spongiotic vesicles with a large vesicle in the center, where we actually end up with some tissue artifact where the tissue is separating because the vesicle is so large. In this case, as we zoom into higher power, we do see some eosinophils. We see eosinophils within the spongiotic vesicles. And then as we evaluate the deeper dermis, we actually see lots of eosinophils in a predominantly perivascular pattern. And then our next slide, whenever we are evaluating spongiotic dermatitis, we always perform a PAS stain. A dermatophyte infection will always be in the differential diagnosis for spongiotic reactions and can sometimes be surprising clinically and histologically. And so in this case, we look at our PAS stain. We always zoom into very high power to evaluate the PAS, and we see some hyphal elements here. So this is a case of an acute spongiotic dermatitis that is a tinea infection. A subset of acute spongiotic dermatitis is spongiotic dermatitis with intraepidermal eosinophils, also known as eosinophilic spongiosis. And in these lesions, we have intraepidermal eosinophils within the areas of spongiosis. Often in these cases, there are numerous dermal eosinophils as well, but not always. And the presence of intraepidermal eos helps to narrow the differential diagnosis. So commonly, we see this in arthropod reactions, including scabies infestations. We can see this in drug reactions, contact dermatitis, and importantly, eosinophilic spongiosis is also one of the hallmarks of the pre-vesicular or pre-bullous stage of bullous pemphigoid. So if there's no obvious clinical correlation, the patient doesn't have any new medications, no family members have a similar eruption that would suggest a scabies infestation, we recommend direct immunofluorescence studies in these cases. And I've actually had cases where there's a little bit of spongiosis, maybe one or two intraepidermal eosinophils that are kind of subtle, and the subsequent direct immunofluorescence is actually positive, and the patient is diagnosed with prevesicular BP. So, so the direct immunofluorescence can be very, very helpful. And here we have a slide, a nice punch biopsy. As we go in, we can appreciate at this low power that there is something within the epidermis that appears like it's probably some spongiosis. And then the dermis at this power is hard to really appreciate, but there probably is a superficial perivascular, possibly interstitial process that we will go higher to evaluate. And as we go to higher power, we see spongiotic vesicles with eosinophils and some Langerhans cells, and numerous intraepidermal eosinophils scattered about. Within the dermis, we also have a perivascular and interstitial inflammatory infiltrate with numerous eosinophils. Direct immunofluorescence was submitted with this case and was negative, and the patient actually had started a new medication, and so this was consistent with intraepidermal spongiosis or eosinophilic spongiosis, consistent with a drug reaction. Subacute spongiotic dermatitis is probably the most common pattern that we see under the microscope, the most commonly biopsied form of spongiotic dermatitis. These lesions show acanthosis, typically some parakeratosis, mild to moderate spongiosis, and lymphocyte exocytosis. There's a very broad differential diagnosis for spongiotic dermatitis that always requires a bit of clinical pathologic correlation, unless, of course, we have a positive PAS stain. And this is another nice punch biopsy, bisected. At low power, we can appreciate some thickening of the stratum corneum in a few areas, so we would definitely want to evaluate that on higher power. Some epidermal acanthosis and an inflammatory infiltrate within the dermis that appears to be predominantly superficial. As we go to higher power, we see some areas of parakeratosis, spongiosis. We don't see vesicle formation, but we can appreciate that there is some increased space between these keratinocytes, and we can appreciate individual desmosomes if we go to higher power. And then the dermal inflammatory infiltrate is in a perivascular pattern composed of lymphocytes as well as a few scattered eosinophils. Another feature in this case are extravasated erythrocytes. So when we see extravasated erythrocytes, we can think of things such as pityriasis rosea, also drug reaction, especially given the fact that we have some eosinophils in this case, or possibly a viral exanthem. Chronic spongiotic dermatitis is seen in the setting of chronic rubbing, and the findings are very characteristic histologically and consist of hyperkeratosis, often with parakeratosis, hypergranulosis, acanthosis that can be irregular but possibly somewhat regular, and fibrosis within the papillary dermis. And the papulonodular variant of this would be Prurigo nodularis. And this next slide is actually a nice case of a prurigo nodule. Often these are submitted with a clinical differential diagnosis of squamous cell carcinoma versus prurigo nodularis. And you can see why. This shows very marked acanthosis, but no cytologic atypia. So we have these very elongated reedy ridges, and then papillary dermal fibrosis, dilated vessels within the dermal papillae, and overlying serum crust. In this bottom section, we actually see some cyst formation at the base, which is also very common with prurigo nodule. Psoriasiform dermatitis is a descriptive diagnosis that characterizes a specific histologic feature, which is psoriasiform or regular epidermal hyperplasia. It can be seen in a number of inflammatory conditions, but the prototype is psoriasis. There are several different subtypes of psoriasis, as you're aware: classic plaque-type psoriasis, guttate psoriasis, pustular, and also erythrodermic. So psoriasis is one of those conditions that can present with a generalized erythroderma and scaling. The most commonly evaluated type of psoriasis that we see is plaque psoriasis, which shows psoriasiform hyperplasia, a diminished granular layer, confluent parakeratosis with intracorneal neutrophils, and also intraepidermal neutrophils forming spongiform pustules within the epidermis. There's typically thinning of the suprapapillary plates. So this is an example of psoriasis. And we can see that above the dermal papillae, the epidermis appears thinned. The distance between the stratum corneum and the top of the dermal papillae is diminished. And we see this very nice regular acanthosis where all of the reedy are lined up at the same level. So higher power, confluent parakeratosis with a lot of intracorneal neutrophils, intraepidermal neutrophils, no granular layer, thinning of our suprapapillary plates. And then within the dermal papillae, we also see these proliferative, somewhat dilated capillaries. The differential diagnosis for psoriasiform dermatitis obviously includes psoriasis, but it also includes some other conditions as well. There can be a lot of overlap between chronic spongiotic dermatitis, or lichen simplex chronicus, and psoriasis. Often we have biopsies that are submitted as spongiotic dermatitis versus psoriasis. And in some cases where we have very classic features, we can make that distinction very easily. In other cases, there's a lot of overlap, and it can be a little more difficult. There are features that can suggest one over the other. So eosinophils would suggest a more spongiotic process. Retained granular layer may be more suggestive of chronic spongiotic dermatitis. But if we're trying to distinguish between a partially treated psoriasis and chronic eczematous dermatitis, it can be very difficult. PRP can also present with a psoriasiform pattern, but the pattern of parakeratosis is different. We see alternating orthokeratosis and parakeratosis, both vertically and horizontally, so it has a classic checkerboard pattern. And PRP will also often show a preserved granular layer and prominent follicular plugging. Psoriasiform drug reactions are also fairly common, and in these we would see dermal eosinophils, and psoriasiform drug reactions are associated with a few medications that I've listed here. So here we have a case where at low power we do see fairly regular epidermal acanthosis and an overlying stratum corneum that appears thickened. A superficial perivascular infiltrate, nothing appears to be going on in the deeper dermis. And then as we go to higher power, we see confluent parakeratosis, intracorneal neutrophils, some areas of intraepidermal neutrophils, a bit of edema within the dermal papillae, and then at higher power, we actually see numerous eosinophils. So this is actually a case of a psoriasiform drug eruption. There can be occasional eosinophils in psoriasis, but if I see more than a few eosinophils, particularly a few within one high power field, then I really start to think about a psoriasiform drug reaction. There are several other conditions included in the differential diagnosis of psoriasiform dermatitis. These can include nutritional deficiencies, zinc deficiency, vitamin B3 deficiency, necrolytic migratory erythema, which is associated with an underlying glucagonoma. Also shows a psoriasiform pattern, but typically has some either pallor, so paler staining of the superficial epidermis, or even confluent necrosis of the superficial epidermis. As with spongiotic dermatitis, a dermatophyte infection is also included in the differential diagnosis. And I always like to perform a PAS stain on psoriasiform patterns. I have seen some cases that really look like classic psoriasis, but then happen to have a positive PAS stain. So that's certainly something that you wouldn't want to miss. And then mycosis fungoides can also appear either as a spongiotic or psoriasiform pattern. Here we have a case that at low power shows some hyperkeratosis. Hard to tell at this power whether it's parakeratosis or orthokeratosis. And then we have acanthosis, fairly regular, and probably some sort of mild infiltrate within the dermis. So at this power, we may be thinking possibly psoriasis, maybe this is a chronic spongiotic dermatitis. But we always want to zoom into higher power. And in this case, we actually see that the epidermis is filled with these large mononuclear cells. Nuclei are in many cases larger than the keratinocyte nuclei. The nuclei are very dark or hyperchromatic and irregular, and many also have perinuclear halos. So this is actually a case of a psoriasiform pattern of mycosis fungoides. This was another case that I had when I was practicing in New Mexico, and it came in as plaques on the extremities, predominantly on the hands and feet, but also arms and legs. And at low power, you can see this very thick stratum corneum that looks very busy, so maybe it has some inflammatory cells. And then some regular epidermal acanthosis and a superficial inflammatory infiltrate. In this case, again, as we go to higher power, we see a lot of intracorneal neutrophils, some intraepidermal neutrophils, kind of forming these spongiform pustules, lack of a granular layer, acanthosis, and then a dermal inflammatory infiltrate that consists predominantly of lymphocytes. But in this patient, when considering the clinical pathologic correlation, the patient was a chronic alcoholic who was very malnourished, and this actually ended up being a case of zinc deficiency. And when the patient was treated, these plaques eventually resolved. The final pattern that we'll talk about in this talk is interface dermatitis, which refers to an inflammatory pattern where the activity in the skin is centered on the interface of the dermal epidermal junction, so kind of along the basement membrane zone. And this interface dermatitis can be subdivided into vacuolar interface change and lichenoid interface change. Vacuolar refers to cleared out spaces along the basal keratinocytes and typically shows individual necrotic cells. They can be called dyskeratotic, apoptotic, or even dead reds. And then a lichenoid pattern, which is a more band-like lymphocytic inflammatory infiltrate that actually partially obscures the dermal epidermal junction. There can be a lot of dyskeratotic cells also in lichenoid patterns, whereas vacuolar is kind of these more individual dyskeratotic cells. Interface dermatitis is a process in which the depth and the pattern of the inflammation is also very important to evaluate. Some entities show a superficial pattern, some will be superficial and deep. Some may show a more perivascular pattern, while others are perivascular and periadnexal. So really looking closely at that dermal infiltrate can help us narrow our differential diagnosis. So one of the classic examples of an interface process is erythema multiforme. Clinically, as you know, this typically presents as targetoid lesions. More severe cases can involve mucosal surfaces and is often triggered by an underlying infection, particularly HSV or a medication. The histologic features are very characteristic. Because it's an acute process, we typically see a basket weave stratum corneum, and we can see single apoptotic cells along the dermal epidermal junction and also within all levels of the epidermis. So in this slide, the top left, we see that there's a split that appears to be subepidermal between the epidermis and the underlying dermis. Maybe there is some epidermal change overlying the split, but it's kind of hard to appreciate at this power. But as we start to go higher, we see that there is some vacuolar change along the dermal epidermal junction in the area adjacent to this split. There's some necrosis of the overlying epidermis. And on the right, at higher power, you see a lot of individual necrotic cells at all levels of the epidermis. So while we do have a vesicle, it's important to look adjacent to the vesicle to see what the true epidermal changes are. And in this case, we can appreciate that this is, in fact, an erythema multiforme reaction pattern that's actually forming a vesicle. So this is a bullous example of erythema multiforme. Higher power of the vesicular area shows that we have a lot of necrotic keratinocytes, but we also have in these intact, more viable cells, intranuclear inclusions and multinucleation. So this is a nice example of erythema multiforme associated with a herpes virus infection. Whenever I see a case of erythema multiforme, I always make sure to look very closely for any viral cytopathic effect. And sometimes it can be subtle, sometimes it's a little more obvious, as in this case. And if we don't see it, all we can do is speculate that there could be an underlying HSV infection. This is another biopsy, punch biopsy, where in the center we have this focus of erosion and then an intact adjacent epidermis. So low power, the erosion really stands out. There's some overlying crust and a superficial perivascular infiltrate. And again, when we go higher, while we do show this erosion, we also want to be sure to look adjacent to the area of erosion so we can see what's happening in the intact epidermis. As we zoom in, we see, in fact, numerous individual dyskeratotic or apoptotic cells at all levels of the epidermis. So another example of erythema multiforme. In this case, it's an ulcerated or excoriated lesion. We don't see any viral cytopathic effect, but the differential would be infection versus medication induced. Fixed drug eruption also demonstrates an interface reaction pattern. Fixed drug can have a superficial or a superficial and deep inflammatory infiltrate, can include eosinophils, which are a helpful clue, and also neutrophils are sometimes seen. Fixed drug eruptions also commonly have a lot of pigment incontinence or melanophages within the dermis. So as we look at the next slide, again, a nice bisected punch. And at low power, we don't see really much change in the stratum corneum. At least at low power, it appears to be normal basket weave pattern. A bit of epidermal acanthosis, and then an underlying inflammatory infiltrate that's a bit band-like within the superficial dermis, and then also shows a perivascular pattern in the superficial reticular dermis. And as we zoom in, it gets a little more interesting. So we do show basket weave stratum corneum, so an acute process, and a bit of epidermal acanthosis, and then numerous dyskeratotic or apoptotic cells, predominantly located along the base of the epidermis. There are a few cells going a little higher, but for the most part, the dyskeratotic cells are located in the lower half of the epidermis. And then as we look at higher power at our dermal infiltrate, we do see a lot of these small blue cells, so a lot of lymphocytes, but also quite a few eosinophils. So in this field, I see just in this perivascular focus, probably 10 eosinophils, which is a lot. The other thing that's notable is a lot of pigment. So we have a lot of melanophages in this case. So the combination of an interface process with eosinophils and melanophages is very suggestive of a fixed drug eruption. I think this is just one more example of a fixed drug eruption at low power. That's a little less interesting than the previous case. But again, stratum corneum appears normal. We do see some acanthosis. And then as we go higher, we see some vacuolar change, some individual dyskeratotic cells, some eosinophils within the dermis, and some pigment incontinence. So once again, another example of a case that has all of the characteristic features of a fixed drug. The last interface diagnosis that we'll discuss is lupus erythematosus. There are several clinical forms of lupus, including acute cutaneous, which is often associated with systemic lupus, subacute, and discoid. Discoid is the most common form and the one we see most commonly biopsied. And it consists of erythematous scaly plaques, often on the face and scalp. And they can be atrophic, somewhat scarring, and hyperpigmented. All forms of lupus histologically show some overlap. So while we there are features that are suggestive of one form over the other. In many cases, as the pathologist, what we can tell you is that this looks like lupus or it looks like a connective tissue disease, but we can't necessarily be more specific than that. The one example that is a little more specific is discoid lupus, which does have some more specific histologic features, including hyperkeratosis, typically orthokeratosis, prominent follicular plugging, and a thickened basement membrane zone. Lupus will often show a superficial and deep perivascular lymphocytic infiltrate with increased mucin. The infiltrate can also be present in a periadnexal pattern. And the differential diagnosis includes lesions that also can show a superficial and deep infiltrate, such as polymorphous light eruption or a drug reaction. Lichenoid keratosis can also be included in the differential diagnosis, but will usually show only a superficial pattern of lichenoid inflammation and is generally a solitary lesion. So here is a punch biopsy bisected. At this power, low power, we can appreciate that we do have probably some activity along the dermal epidermal junction. And we also have a fairly robust superficial and deep inflammatory infiltrate that appears to be perivascular, but also surrounding hair follicles, so perivascular and periadnexal. So even at this power, we start to think, oh, this is very suggestive of a connective tissue disease and may represent lupus. As we go to higher power, in this case, our epidermis is a bit atrophic. We see some vacuolar change, and in some areas, the basement membrane does appear to be thickened. And then we have a superficial and deep, perivascular and periadnexal inflammatory infiltrate that is composed predominantly of lymphocytes. And we also see some interface change along follicular epithelium, which is very characteristic of connective tissue disease and lupus in particular. This is another example where at low power, we have a nice deep punch biopsy with some hyperkeratosis and these dilated follicles with keratin plugging. So as I mentioned, these are features of discoid lupus, and this is a very characteristic picture that we would see in discoid lesions. There is a perivascular and perifollicular inflammatory infiltrate that extends deep. And as we go to higher power in this case, we can appreciate this very nice thickened basement membrane. If we wanted to highlight that basement membrane, we could do a PAS stain, and that would really show us and accentuate the thickened areas. Lichen planus is the prototype of Lichenoid dermatitis, just as psoriasis is the prototype of Psoriasiform dermatitis. I've included the clinical features that are typically seen. The histologic features are very characteristic. There is classically a band-like lymphocytic inflammatory infiltrate along the dermal epidermal junction, prominent epidermal acanthosis with what are described as sawtooth 3D ridges, wedge-shaped hypergranulosis, and hyperkeratosis. And the differential diagnosis for lichen planus is fairly broad. It includes things such as a lichenoid drug reaction. Lichen planus will typically show orthokeratosis and a lymphocytic infiltrate. A lichenoid drug reaction may show areas of parakeratosis and include some eosinophils within the dermal infiltrate. So those are the main features to look for to differentiate between lichen planus and a lichenoid drug reaction. A lichenoid keratosis can appear histologically exactly like lichen planus, but again is usually a solitary lesion, often on the chest, middle-aged female, So we really rely on the clinical pathologic correlation for that as well. Lichen striatus superficially can look like lichen planus, but is a nice example of why a punch biopsy is very important in these cases, because lichen striatus also includes a deeper inflammatory component, classically in a perieccrine pattern. So here we have a nice punch biopsy. We see our thickened stratum corneum, stratum lucidum. So this is consistent with acral skin. At this power, we can appreciate very nice wedge-shaped hypergranulosis and a band-like infiltrate within the papillary dermis that is kind of obscuring the base of the epidermis. And we see a kind of a sawtooth 3D ridge pattern. As we go higher, we see the infiltrate is composed predominantly of lymphocytes. There is this obscuring of the dermal epidermal junction and some scattered dyskeratotic cells. And this is a nice higher power view of that wedge-shaped hypergranulosis. Here is another case that at low power appears very similar to the previous case, except we do see a little area that's suggestive of some parakeratosis. We have a nice band-like infiltrate, wedge-shaped hypergranulosis, obscuring of the dermal epidermal junction. But at higher power, we do have this focus of parakeratosis. Over to the right, another focus of parakeratosis. And as we zoom in on this infiltrate to find them, but there are some scattered eosinophils within this case. So this is an example of a lichenoid drug reaction that really looks very similar to a classic lesion of lichen planus, but we do have those clues, including the parakeratosis and the occasional eosinophils that let us know that we're actually dealing with a drug reaction. Here we have a shave biopsy. This was a case that was submitted as rule out BCC, so not, which tells us it is a solitary lesion rather than a rash or a more diffuse process. And it's a bisected shave. At this power, we see a band-like inflammatory infiltrate along the dermal epidermal junction. It's hard to even really appreciate the reedy ridges until we go higher. And as we do go to higher power, we see an infiltrate composed predominantly of lymphocytes and several scattered dyskeratotic cells kind of throughout the epidermis, so almost suggestive of an erythema multiforme pattern. But given our clinical impression of basal cell carcinoma, solitary lesion, has a lichenoid appearance, this is consistent with a lichenoid keratosis. And then our last slide, again, nice bisected punch biopsy. This actually goes very deep. We have some subcutaneous tissue here. So this would be a great biopsy if we were looking for paniculitis. And we see a superficial inflammatory infiltrate that also extends into the deep dermis. As we go higher, we see a band-like and perivascular inflammatory infiltrate with some areas where the dermal epidermal junction is obscured, a few dyskeratotic cells, and as we go deeper, we can see that this deep component is actually present in a perieccrine pattern, which is very characteristic of lichen striatus. So you can see why in this case a punch biopsy is extremely important, because if we did not have this deep component, we would only have the superficial component, and our differential diagnosis would be other lichenoid entities, but we would not be able to say definitively that this is a case of lichen striatus. So that is our last slide for this talk. We are going to follow this up with some discussions of pustular and granulomatous dermatitis and also vesiculobullous dermatitis. And then following that, I will prepare some unknown slides that we can sort of go through and discuss that will include examples of many of these different inflammatory entities. So thank you so much for your time, and I will see